It's leather bound. Well, actually, it's 100% leather. Built leather. So, thank you. All right. Our next speaker is Scott Persinger. He's going to introduce himself real quick. He had a small change in his biograph, so hopefully he'll explain to you a little bit more about himself. And he's going to be speaking on elder abuse. So please help welcome Mr. Scott Persinger.
Backstage, and I got a little nervous. I don't want somebody to look at the program and thought, okay, time to go. So thank you for not running away from me. Seriously, I don't do many presentations, so I'm kind of laid back, really. I mean, I may look formal, but guys, I'm not. I encourage you to ask questions whenever they come up. Call me Scott. Just don't throw anything at me. I have been a social worker now for almost 26 years. I've been very blessed to have worked in some great places. The VA having been one of them for my social work internship. That was more education for me in that 6 months than I had all those years I've spent in college. I've mostly, well, exclusively worked in behavioral health. Most recently, I was at Christus, Santa Rosa, where I worked as a social worker for the geriatric adult unit they have. And I realized how challenging that position was. Seeing these folks come in the condition they do is heart-wrenching. Not to knock anyone, but everyone is overwhelmed. They can't do the kind of care they want to do in most settings, especially in the public sector, private sector. And even more so now, as I age, this topic is very important to me. I must say I was very impressed with Dr. Shade. She was so well organized, presented so professionally. Maybe I'm not a great follow-up act, but no, not me. I'm going to just talk, and I want you to talk to me if you have questions. Elder abuse is a growing problem. I see less of that now than I did when I was at Santa Rosa and in other settings. I currently work at San Antonio Behavioral Health. What is it? San Antonio Behavioral Health Care Hospital. It's a mouthful. I'm now doing admissions over there, and they're just getting up and running. So I haven't seen any of the older folks yet, but we'll have them eventually as we're up to full speed. I also have a small private practice where I see anyone over 18. I do this kind of work because I love it. I like seeing people feel better. I like seeing their lives improve. I like to instill hope in their lives. And that's one big thing that you don't see very often, especially in the sicker elderly population. They figure they're at the end of the line. What's the point? I'm going to try not to bore you with statistics, but this is the kind of thing that we really need to look at because it is a growing problem, and none of us want to be on the receiving end of it someday. So in defining abuse, there are the usual types you might think of: physical, sexual, neglect, exploitation, emotional abuse, abandonment, big problem, and self-neglect. As their mental condition deteriorates, they become more difficult to work with, maybe even combative. It's not because that's who they are. It's because of the condition they're in, and they're scared. They are scared to death. I think empathy is the most important thing a healthcare worker of any stripe needs to have. Yes, the clinical knowledge is important. But to fail to feel what that, or at least put yourself in a place, how would I want to be treated? With our busy lives and our busy professions and more demands being heaped on us every day, it is more difficult to be able to focus just on the patient, because there are so many other things that compete with the patient. And these things often get missed. Not by anyone's fault or neglect or lack of caring, but we live in a fast-paced world, and it's getting faster. Our task is to keep up. Not as easy as it used to be. Look for the warning signs when you meet with someone. They're the obvious ones. They're bruises, frequent falls, have a kind of a dicey explanation. There are behaviors. The number one thing we see is withdrawal in the patients as this kind of thing happens to them. Even small comments are can be belittling to the client. Oh, this is so much trouble. Oh, I'm so overwhelmed. My mom is still living. She's 78. I go through that with her a lot. In fact, I'm having to step up what I do to help her, which I'm glad to do. She raised me and did a pretty decent job despite the odds. But look for the obvious things first. We all do, automatically. A bruise. Oh, I fell. I hit a doorknob. Yeah, right. Focus on the smaller signs. Is this person withdrawn? Are they talking quietly? You have to ask yourself why. Is it dementia? For some it is. For others, there are other intervening variables that happen randomly and totally unpredictable, that get these folks in the condition they're in. Not so much the dementia. We understand the biological processes of that. We understand the impact it has on all areas of their life. There is a part of me that's not very professional when it comes to abuse of children and the elderly or the disabled. I get pretty riled up. It's hard not to, but you have to keep your professional demeanor. So without going over these in great detail, unexplained emotional withdrawal. Are they living alone? Or do they live with a family and they're pretty much relegated to a room, not included in activities, things of that nature? It's not outright neglect or abuse. It may be their choice. But from small seeds, big things grow. I think it's important to keep that in mind. This is a national elder abuse study where I glean most of all of my statistics. So I don't have a wonderful model like Dr. Shade presented. I guess I'm always considered myself the frontline guy. And we are, those of us who are hands-on. In her setting, especially with veterans, you're going to see things that most of us won't in the community that don't see veterans regularly. Whether it's from a nursing home or a provider or a family member. Things happen that are really very disturbing. So see, I didn't make these numbers up. I just want you to know that. Here's the source. Look at this. 2,150,000 elderly abuse cases each year. That's shocking. We do this to our people, our families, our mothers and fathers, our aunts and uncles. I must say, as I went through the the study and other sources as well, I was very shocked at some of these numbers. I knew it happened, I didn't know how much. Now, this is an old study. I believe it was 2000, oh no, okay, it was in July, not that old. Look at the cultural differences. White victims, more so than in the black community or Hispanic culture. Not to knock us white folks, but let's face it, these two cultures, the black and Hispanic community, have a reverence for their elderly that still exists. We do too. But I think that's why there's a lower number. Maybe I'm wrong. Maybe it's underreported. You always have to wonder about that. Look at the percentages. Neglect, number 1. Oh, mom's okay. I'll go check on her next week. Physical abuse. I remember when my mother was taking care of her mom. And she called me one day just very upset. She said, "Oh, Scott, I'm awful. I can't believe I did this." I said, what are you talking about, Mom? She said, my grandma was bedridden in the last month or so. She and my stepfather took care of her until the last, at the end. But she said, "I got so frustrated, I shook the footboard of the bed." I said, "Mom, yeah, that wasn't cool, but that's not abuse. You didn't hurt her because you hit her." I mean, I went through, my social work brain kicked in. I went through everything, and I tried to assure her that that was not, yes, while it wasn't a good thing to do, it was because of caregiver burnout. I suspect that's where a lot of these abuse and neglect cases come from. Are there any questions up to this point, or statements? Anything you want to share? No? Y'all are awake, right? I got up this morning and looked in the mirror and I saw the graying hair, and I realized that the Just for Men product should be changed to just for a little while. So, I'm sorry, I inject humor. I have to. You gotta laugh sometimes, even along with dealing with something like this. There's so many bad things, so many horrid things that happen to people in this world. This is something we as providers, professionals, and those of us who have loved ones as they age can intervene. It doesn't take much. How do we intervene and how do we prevent this? I wish I knew. We can try, we can talk about it, post things on Facebook, but do people really listen? Not totally there, not totally ready to do it. It's important to thoroughly assess these folks when they come in to see you, whether it's family that brought them in or they come by themselves. We have to understand what their situation is, and it is difficult. Some of them don't want to talk, especially the older generation. There are a lot of issues that they will not talk about. If their son slaps them, calls them names, you know, as parents, we're very forgiving, sometimes too forgiving. But they don't often come out with that, and those pointed, directed, closed-ended questions have to be asked. Be aware, that's number 1. Ask, that's number 2. It's important to have a comprehensive cognitive assessment. On our part, we don't have to go through the entire full mental status exam to get an idea of where this person's at. We look for everything from emotional, behavioral, the thinking process, how they interact, what the warning signs are. That awareness is key to identifying and preventing the abuse of anyone, not just elderly, anyone. If you suspect it, don't blow it off. Don't say, oh, Mom doesn't know what she's talking about. That wasn't abuse. Telling somebody they're a pain in the butt when you're helping them change their diaper. How many of us would do that? Remember, even though we're professionals, even though we care, we are not perfect. We have to police ourselves. Once you have an idea of how well that person's brain is functioning, you've got to proceed with the assessment. Ask the questions. If it's something above your head, get a nurse. Get a second opinion. Consult with somebody. Somebody who can help you get to the bottom of what's going on. Screening questions need to be brief. You might guess by now I'm pretty personable with people. I sit down and I'm right there, face to face. And I ask them questions like this. How's it going today? Get the patient history. If there's violence in the family, economic problems, long-standing relationship problems, all of those things can have impact on whether or not that elderly person is abused or neglected. Talk to the family. Have you ever met a family who paints a really rosy picture? Yeah. Then you find out, as the watercolor washes away, that wasn't such a cute picture after all. Verbal abuse is probably the thing I heard of from clients more, or hear of from clients more, than any of the other types. You demean someone's character, or you get after them because they're doing something they can't help. So part of me believes that registers with the person, and I don't care how far gone they are mentally. It registers with them. They feel it. Check with your supervisor. We know what to do when we see abuse. If we're out in the community on our own, if we're seeing a patient in our private office, if we're talking to a friend who confides in us that he got angry and withheld food from his mother or father, we know what to do with that information. We report it. Met a lot of great people with Adult Protective Services. They work so hard, and they are so underfunded and understaffed that if something doesn't happen to fix that, we're going to see these numbers skyrocket. Implementing the interventions, that's the hard part. How many of you had to tell a client or a family member, I have to report this to Adult Protective Services, Child Protective, or any other authoritative agency? It's hard to do. You don't want them mad at you. But you also don't want to leave somebody unprotected. And sadly, that happens all too often, as we see by the numbers. Protection and abuse protection and support. If we have to, do a social admission. Get them care. Get them out of that situation. Send the police. You guys know what to do. Additional support for less frequent concerns. I'm not the best social worker to send in to link people in the community since I've focused so much on clinical work. There's a lot of things I don't know that are out there, and I'm still learning that I don't know everything. When you assess someone, can you see those deficits? An evidence-based approach will give you that information. And yes, ask those hard questions. What's your house like? You have pictures up on the wall? What do you think about? Do you think about your family that's already passed on? Get that information. Are there substance abuse issues with that client or in the family? It's kind of scary when you think of all the warning signs that are out there. And all these things happen so frequently. Sorry, I'm not supposed to turn my back on you, I guess, but sorry. I'm sure you all are awake. I don't even hear much rustling out there. No bones snapping. I mean, no joints snapping or anything. For further study, I'll leave this up a couple of minutes if you want to look at a good clearinghouse through the government for aspects of elder abuse and neglect. That was a pretty good source. If you don't know,
you put it back up.
Oh, see, I lied. I said I'd leave it there. Can't trust us so much. You're welcome. I think I'm getting close to end on my slides, so I really need to hear something out of you folks. If you're unsure, if you're questioning, if you think, well, nah, that's not reportable, ask someone, consult with someone, have them talk to the patient. If you're a private family member, ask that information and report it to the next professional you see, or call child or adult protective or whatever service is available for you and run the case by them. I think they consider me a little off in Austin. I probably am.
Everything's off in Austin.
Boy, ain't that the truth. Let's not go there. I could spend hours. I call them and say, here's what's going on with this patient. After the long wait, it's another sign of an overstressed system. Not the fault of the people, the ground forces. I told you I was getting close to the end of my slides. I appreciate your attention today, and please, questions, thoughts, things you've dealt with, bring them up. How many of you have a parent living in the home with you? How many of you are going to have a parent living in the home with you? It's going to happen. It's a reality we have to face. Nursing homes are expensive. Insurance doesn't cover all the costs. And with the way things are now in this economy, we can't pick it up. I work 2 jobs full time. I couldn't pay $1,000 a month in addition for a nursing home, or to get a private room to pay several $100s a month. Couldn't do it.
I have a question.
Yes, ma'am.
I had a situation at a hospital, and I was working on a temporary basis with a friend, and it was definite abuse. A transport person was very irritated with a patient. I was at the desk, and I heard this loud noise, and I leaned over the counter to look to see a woman that weighed all of probably 69, 75 pounds up on the gurney saying, help me, help me. The transport person said, I'm sick of her, ran her into the counter while all the nurses in the station watched. and I felt like I was gonna throw up. I was there on a temporary basis, so the person who had asked me to assist was not there that day, so I emailed her and said I needed to speak with her immediately, hoping that this would be followed up and there would be a report written. She came in 2 days later, no report was sent in.
Oh boy.
Transport person was never taken care of. All of the nurses standing there at the counter, which there must have been 8 or 9, no one wrote an incident report. As I was sitting there, one of the nurses screamed at me and said, I need you to go get a doctor right now and tell them she's delirious due to the disease. And I turned to the nurse and I said, I'm not doing that. And about that time, a friend of mine who's a cardiologist came walking down the hall and I said, Mark, please go in that room immediately. That patient needs intervention. And of course, Mark went in there. I went to the EAP, whatever it was called. I went to Human Resources. I went to every person in that hospital within the next 2 weeks to report what had happened. They turned on me. They wanted to know why I was so interested in making a difference and basically told me, thank you for your time. Nothing was ever reported, nothing was ever done. This is one of our biggest hospital systems here in San Antonio. The only thing they did say is we do have a lot of problems with that floor and we're sorry that you had to be a witness to something like that. What more could I have done? Called APS? I mean, I went to every tier I could in the chain of command. The only person I stopped short of was the CEO. And I still think to this day I should have went to the CEO.
Board of
Yeah.
examiners too.
Yeah, definitely. That, you probably saw me start to turn red just hearing that story. That's the part of me that's not professional. I'd go ninja on the person. Cops keep pulling
We
me
got
off.
someone from the APS right here.
I'm sorry?
Actually, what you would do, anything that occurs in a hospital is Department of State Health Services and JACO. Adult Protective Services does not investigate what goes on in licensed facilities and hospitals.
That is true. They will not.
So it would be dishes.
And no one ever, I'm not an RN, I'm not a licensed medical professional, and no one ever gave me that channel or that avenue, which to this day I'm still angry because that could have been my mother, that could have been my sister, and I'm sitting there thinking they're in hospital systems to be cared for and to be taken care of. And to this day, when people say my mother's in the hospital or my sister, I tell them, don't you leave that hospital.
Yeah. 24 hours, 7 days a week with that person, somebody, anybody, to be an objective source or not so objective, but to watch. What's that medicine you're giving it? Why are you giving it to it? What are you putting in the IV? Oh, it's just medicine. I know that. What is it? What's it for? What's it do? What changes might I see?
I work with regulatory services, and I know that all hospitals and nursing facilities, adult daycares, assisted living, they all have to have the hotline number of whatever entity regulates them. So what I would encourage people to do, if they're non-professional and don't know that, then begin seeking where is the hotline number for complaints. And they cannot, you know, I mean, I'm not saying that somebody won't say something to you, but you don't have to report it to anybody internally.
That's right.
You go straight to that, especially if you saw it. If you see something that you know is abuse or neglect, or even suspected. As a regulatory person, I always told people, err on the side of caution. Because APS workers and regulatory service workers, we're not after, you know, we're not out to get anybody. But we would rather make sure that if there is abuse or neglect, that gets taken care of, that gets reported, and then we follow up on it. It's not that easy to prove if there's not an eyewitness, but it's still, we have to show a preponderance of evidence, which is a legal term that says if it's 51% more likely to have occurred than not likely. That's all that APS or a regulatory service or a JCO has to do. And then it goes into maybe the legal system if they say, yes, it did occur, and there's follow-up. But I would always encourage you to look for, and if you can't find it, then ask someone, where's the complaints hotline number? It's got to be posted in an obvious place. It has to be posted and clearly able to see it.
Yes, it does. And those signs are getting bigger, thank God.
Yes.
Yeah.
Some of them are that little itty-bitty print, like you need to be a lawyer just to read it and have a big magnifying glass. Not anymore. You
The
see
more
those
information you can give, the better and more likely it's going to be found to be true. It's very important that you give everything that you can think of.
Well, I assumed that the hospital had verbal and behavioral integrity, and that JCO would be a part of that natural channeling.
Yeah, don't assume that.
Yeah,
Well,
no.
I learned that, but I have a marketing background,
Yeah.
and, you know, I'm familiar with JCO, but I didn't know that I was to take the baton all the way to JCO. Otherwise, I would have.
And JCO and the health department, seen by administrators, nothing against any of you, are the devil incarnate. They don't want to see him walk through the door.
Scott?
Yes.
Oh, it's Jill. As a care manager, I see a lot of families with burnout, working with a lot of clients with dementia and Alzheimer's. Some resources that might be helpful to the group is the Alzheimer's Association. We have a board member here, Valerie Taylor. There's a number of us that volunteer for this group. They're just down the road. They're an excellent resource for families through support groups. If these people are stressed, they need an outlet, they need resources, information. I know earlier we were talking about resources. They have lists of psychiatrists, they have lists of elder law attorneys and different groups that families can have mailed to them. That's one group. The other group is the local Bear Area Agency on Aging. They do benefits counseling, everything's free. These are your taxpayer dollars coming down from the department it's through ACOG, the Alamo Council of Governments. But when you call their Alamo Service Connection number, you can get information on how to pay for care. You can also get free legal help. They have attorneys through the Bar Association that can do wills, powers of attorney, and this is for elderly, there's not a cost. And they also do care coordination, similar to care management, for up to 30 days. So if someone's in crisis, you can have someone do care coordination and help that family get medical equipment and services in the home. And in addition, there's personal assistant services. We have a few people here that work for non-medical care services. And you've got services that cost money out of pocket, but through programs like aid and attendance that veterans are eligible for, and through Medicaid and other services, you can have services either covered or paid for by different entities to give that family a break.
Yes.
And so people need respite, they need breaks. Respite could be taking your loved one to a facility, or it could be having providers in the home.
And if y'all don't know Jill Trevino, talk to her. She has her own business, Gray Matters. She does private care management. She is a great resource. I leaned on her a lot in my time in Santa Rosa. Talk to her. She's a great resource. Nice lady. I know I'm shamelessly promoting somebody, but I believe in her. I think she does a great job.
We had a question right here.
I'm sorry?
I was just going to tell you also that ACOG will also have caregiver training, and it's all free, and including stress management, and they also have benefits counselors. So if a person doesn't know what their family member has available to them, they'll help you with that financially, and they'll tell you what you're eligible for. So there's a lot of stuff, and a lot of people don't know about Area Agency on Aging.
Yeah. There's a lot out there. The problem is it's not well coordinated. It's not well. Probably one of the best resources is to call the crisis line or the United Way helpline. They can give you most anything. My brother is a master's level counselor. He's been the executive director of mental health systems up in Kansas for several years in the public community. And one thing you see about Texas, and I'm not knocking Texas, okay? But let's face it, if you're not a cow, an oil well, or a highway, you don't get a lot of services. You don't know who to call, you don't know where to go. But there are people out there that will know. And if you call them, you keep calling, be persistent. And I told you, I don't know everything, I'm more of a clinician. It's people like these that are speaking up through personal experience, professional experience, and through the jobs they do every day. They have that information. We need a clearinghouse. I don't know if there's one central one. I don't believe there is for the state of Texas. ACOG is about as close a model as I've seen, and I encourage you to use that as well.
477-3275.
Or 211.
Or 211, right?
But if you want to go straight to the Bear AAA, that's the 477-3275.
Did everyone get that number? Right.
Give it a number tomorrow in my presentation on resources.
Oh, excellent.
So there will be something provided.
There are several people attending today that work for PAS companies, personal assistant services. I work with caring companions. I was compelled through several experiences in my life that people will care, and we are going to take care of people, and there's other people pride attending. All you have to do is look around, and we can end this, but we have to be vigilant.
Yes. And the problem.
Just step in there. Good morning. I just want to offer this as food for thought. First of all, I work for an organization here in San Antonio, a very large medical organization, and we collaborate with the city of San Antonio in the senior centers. We have half a dozen senior centers here in San Antonio, and part of the program for our senior centers is the Caregiver SOS. And so we have infiltrated the community with these senior centers, and so there are resources there. But the other thing I wanted to mention more as food for thought is that by popular literature, longevity in the United States was about 69 years old. And so now we're like upwards of 80. Yeah. And so I'm wondering, you know, if the problem has actually escalated because of population. The other part to that, I was hearing a program on NPR last week, I think it was, and the fellow has a website called Our World in Data. I haven't been to the website yet, but I'm curious what the data is now as opposed to 20 and 40 years ago.
Our World in Data?
I think it was called Our World and Data.
And Data. Okay.
And Data. And what the guy was saying is that according to the data, he was making a contrast between all the doom and gloom that we hear in the news right now versus what has gone on historically, that we actually are nicer to each other now than in centuries past. Oh, because beheadings and crucifixions were like, off with your head, you know. It was just a part of everyday living, and so that might have been part of the longevity too. But I would be curious to look at
that. Makes a difference. It does.
I would be curious to see that website and see what the actual differences are, and if he addresses things like elder abuse. Thank you.
No, thank you. That proves my point about always, always, always consult with someone. We don't have all the answers. If you think you do, go find another job doing something other than human services. Now, it is a growing problem. Being on the tail end of the baby boom years, I think it was, what, 65 was the official end, 20 that generation. I'm on the tail end of that. I won't tell you exactly where. But it will continue to grow as a problem. Unfortunately, and again, not knocking anyone, if it's not a tangible resource like a check, Lone Star card, something, a weapon. It has to do with services to the individual, to the family. See, my dementia setting in because I forgot my basic thing was, it won't be as eloquent as I had hoped, but basic point is, if it's not in the national spotlight or in the community spotlight, it gets ignored. That's why you have to ask. Kids ask, Daddy, why is the sky blue? Beats me. It just is. Why is it that way? Well, it just is. But we're the ones that can change it. You see all kinds of great innovative ideas coming to healthcare now. Whether it's small end or corporate or public. Small end, I don't mean like useless, but private. An individual, a group, an entity. They're starting to turn around.
Sir, I have a question, or a comment actually. I'm in long-term care setting, and on the topic of abuse, and like you said, with the burnout for caregivers, also with the nursing staff, you know, the CNAs I see, and I understand the training, but also I think overall it's mostly because there's a shortage. And I wanted to know, but even, you know, PA, you know, I know there's veteran homes. I know there's waiting lists for that. What are we doing to get more? I know there's a short, I mean, we knew that like 20, 50 years ago, I guess, you know, there was going to be a shortage. And with an older population, and I know even from where I'm at, I'm in a rural area, we're struggling for CNAs. And, you know, and I go and see, you know, now there's some that do training. I don't do training yet. But CNA courses are, you know, $800 to $1,900. A lot of these CNAs who want to be a CNA, they don't have that money. So, I mean, is there an initiative, I mean, for Texas or national, you know, we need the caregivers as well. And I think that's part of, and probably a major factor with the abuse because of the burnout and the shortage.
It is. And there's always a factor of families not wanting to report a caregiver because they like them. I had to turn my phone on to look at the time. Sorry. It's like a lawsuit. You don't want to sue a doctor that you like. And statistically, a doctor, and use it as an example, not for any reason except they are part of the frontline people that are out there. You don't want to sue a doctor you like, so you may blow things off. You may do that with a social worker. Now, malpractice insurance is a lot cheaper than the doctors. Thank God I've been lucky. I've never had a complaint that I know of. And you know. But anyway, I digress. If you see something, if you hear something, get to the bottom of it. Practice that due diligence. As for what's being done, I think it speaks to the strength of our country. I'm going to kind of out myself a little bit here because I like to see individuals and small groups do things more than I like to see government do it. Nothing personal. Innovative ideas. 20 years ago, there was maybe three or four senior care management private outfits in San Antonio. I don't know how many there are now. I do know it's needed. There's about 100 and, well, someone's quoted 92, I've heard 150 nursing homes in San Antonio. I believe it's in the lower 90s. But if you look at not only nursing homes, but personal care homes, boarding homes, private homes, I don't know what the percentage of people who receive that type of care from either a family member or a professional. I don't know what it really is, but I do know this. As we age, we're going to experience it. We're going to find out. We don't want to be on the receiving end of what I've talked about here today. I really appreciate those of you that spoke up. That information is so helpful. I learned something. I appreciate that there are so many people who care. We'll never get rich, but that's okay. Can't take it with us anyway, right? But we do a very important service for other people, and that is we care about them. Yeah, you got to turn it off when you go home at night. Sometimes that's not easy to do if we have a moral conscience. Use that in everything you do.
Can I just add one thing?
Sure.
Okay, I am a staff ombudsman with the Alamo Area Agency on Aging, and we do the same services as Bear Area Agency on Aging in the 12 surrounding counties. Within those services of caregivers, we assist the caregivers as well as the residents and protect the residents' rights while they're in the facilities, nursing home and assisted living. The caregiver services, there is respite service also provided by our agencies, which is to help with that stress and help with that aspect of, you know, when just they can't handle it anymore.
Yes.
And so I just want to be sure that is noted and everyone knows that. In regards to what she was saying about lack of aides and staff, that is a national problem.
Yes.
And I encourage everyone to let their congressmen and their representatives know that it is a problem. We're trying to make it more noted. We're trying to make it nationally more informed about that to help with that aspect of, you know, trying to get more people in the facilities to help, to be able to have a little more extra relief so there is not abuse. I also encourage everyone that if you have a family member in a nursing home or assisted living, be involved in their care, be involved in them. Don't just place them in there and forget them. Thank you.
Thank you. Are there any other questions or comments? We got one more? Yes.
Good morning.
Hi.
Hi, Scott. My name is Whitney, and I just wanted to share with the lady. I know you. With the lady right here, you said you work in long-term care. I do as well. I work at a skilled nursing facility. And one of the things we have done is over the past year, we started a free CNA school. We work with the state, and we allow people to come in for 3-week courses for CNA training, and then they can test. It's free. The only thing they pay for is their uniform. So,
wow.
And an open watch.
How do we find them?
Well, the name of my facility is Meridian Care Grayson Square. They just come in and fill out an application. They do go through like an interview process. They only allow about 10 to 12 students per class, so it is very competitive. But I just wanted to put that out there with the staffing issues.
That's what I mean right there about innovation. That innovation, it came up from an individual's mind. And it's coming to fruition. That's what's needed. Anyone else? I got to tell you, I was a little worried when Dr. Cawthorn called me and asked me about presenting. Well, the first thing he said was, Scott, I want to talk to you about dementia. I said, oh my God, does she know something I don't know? I was very honored to be asked to be here. I appreciate the participation. I hope this presentation was beneficial for you. And rely on one another. Look at all the information that came out here today. That's what will make the difference. Thank you, and God bless you all.
Okay, thank you so much, Scott.